All right. Hi, welcome. I'm Morgan, and Renee and I are here with a special guest for Sexy Self-Care with Parenthood Prep. And Renee is going to introduce our guest.
Yeah, so we're really excited. This woman is absolutely phenomenal. She's a physical therapist, and she specializes in treating women throughout their lifespan. She has two offices, one in LA. I don't know where the other one is. You'll have to tell us that in a minute. She's also the author of a book called Sex Without Pain, a self-treatment guide to the sex life that you deserve. So come on, ladies, like how many of us have this issue, especially after childbirth, and there's no one to talk about it with? So this is your woman, and this is Heather. We want to welcome you to our Sexy Self-Care.
Hello, thanks for having me.
Hi, you're welcome.
So we just wanted to we just wanted to start off. We start off all these by asking you, what do you think of when you hear sexy self-care? What comes to mind for you?
Well, one of the biggest things is, making sure that women are experiencing the sex life that they deserve. I mean, that's sort of where the title of my book came from. And, if they're not, what can they do to take care of themselves? And so they can achieve that level of, the highest level of intimacy and sexual contact with their partner.
That's fantastic. So, I mean, let's just dive in. Like if I'm a woman experiencing this stuff, what can I do? Because it feels so frustrating. And I think that even like some medical professionals, they don't know, and they give like kind of shitty advice.
Yeah, it's very true. The number of women that I've had in my office where the advice that they received from their physicians was to have a glass of wine. And, that's awesome advice, right?
I do love wine, but
like alcohol is the cure for everything. So, that or just, being told that they must have some like sexually transmitted disease because that's why it hurts. I mean, just horrible things that just, mess with their psyche and mess with their relationships with their partners they currently have. And, that's kind of the first thing that I hear from patients is like that level of frustration that they're experiencing. And, most of them they're not told right off the bat, oh, you should go see a pelvic floor physical therapist, which is what I am. Mm-hmm. And, what we do is after we evaluate them and which, is a part external exam looking at muscles and posture, but also part internal exam where it's, vaginal exam, looking at muscle tone, trying to reproduce their pain, finding what muscles internally might be guarding or in spasm and limiting their ability to achieve full sexual function. Mm. And, we do that in the office through a variety of ways. Most of it starts with manual work. So, me using my hands in the office, but teaching you how, or the patients, how to mimic what I do in the office as part of a home program using a tool called a dilator, which is just a plastic rod that is a medical device that you can use for doing certain internal muscle techniques and muscle stretches, but all very internally focused at first.
Okay, it does sound a little bit intimidating, the instrument. Is it as scary as it sounds or no?
It kind of looks, it's less scary maybe than a vibrator might be to somebody because it's just smooth and either plastic or silicone, or silicone, I should say.
Uh-huh.
It's just very formless, it just is kind of rounded at the edge and, has a shaft, but it's intimidating anyways, just because inserting something is what is like the most anxiety provoking for these women. Like it kind of brings up the fact that that's what they have pain doing. So it's a little bit of, I'm not a psychologist. I always tell my patients, like I only have a psych minor, which I do, but I'm
I like that.
Never trying to actually counsel them, but only in the way of being like a cheerleader for them, a source of like inspiration and encouragement. Mm-hmm. And, most patients, honestly, well, I won't say most, I'll say a lot of my patients can't even insert a tampon without pain. Like that's how severe their muscle guarding is. And most of those patients, I'd say 90% of those patients that are at that level where tampons hurt, within 1 or 2 weeks are able to insert a dilator that's the size of a tampon without pain. So that's one of their first goals is like, you know, summertime, I'm like pool party, like let's get that dilator, you know, going. Pool parties and you can wear a tampon and they love it. You know, I try to, you know, joke with them a little bit. I know it's a very serious topic, but you know, you can't be really sort of, you know, really too serious about it. You got to be a little lighthearted to make them feel comfortable with you and, you know, be that inspiration for them so that they'll want to go forward.
Yeah, absolutely. So you said muscle guarding. I have an idea of what that is, but can you explain a little bit more?
Yeah, so basically, it's sometimes hard for people to understand vaginally, so I'll always describe it first using other muscles. So example, you know, if you have whiplash in your neck and you can't turn your neck, you know, like you're moving your whole shoulders back and forth, the neck won't move. And if someone tries to move your neck like really forcefully one way, your neck will actually overcompensate and go the opposite direction, thereby losing more motion. And then it'll take a little bit of undoing to even get your neck straight again. And so the same thing happens with these repeated attempts at intercourse. They're kind of like trying to really quickly overstretch it, and then the muscle recoils and clamps down and gets tighter. And that actually slows down recovery and it makes it worse both physically, because whenever you overstretch a muscle like that, it will recoil and get tighter. But then psychologically, it'll also be more devastating for them, because another thing that, you know, doctors have told them many times is, you know, just keep trying, it'll get better, just keep trying. And for a lot of these women, it just gets worse with repeated attempts. And it's really sad.
So discouraging.
Yeah, it is. And, you know, so the pelvic floor physical therapy, just like traditional physical therapy in the neck, is aimed at doing muscle techniques to relax that guarding, that tension in the muscle, try to restore a normal amount of stretch. And the ultimate goal is that now, you know, the vaginal muscles can stretch without pain. Whereas previous to them coming to PT, they either couldn't have sex at all or insert a tampon at all. Or they could have sex, but it was excruciatingly painful. So
they're just kind of gritting their teeth and doing it.
Their teeth. Yes, I was just reading an article this morning on Huffington Post Women about a woman journaling her experience essentially with vaginismus or vulvodynia. These are some of these medical terms for painful sex. And she started off, you know, as a letter to like herself 10 years ago when she first became sexually active, and then, you know, just kind of moving closer and closer to the future. And that's how it was when it started, just gritting her teeth. And, you know, as far as her partners knew, she was having a great time, but, you know, inside she was not having a great time. And it just did continue to get worse over time until, you know, 10 years in the future, she found a pelvic floor physical therapist and is now enjoying pain-free sex. So she had only known, you know, 10 years ago what she knows now. She wouldn't have had, you know, that all of that, you know, 10 years of trauma to her psyche and to her physical state.
Mm-hmm.
So it's actually much more common than we know, right?
It's really common. You know, research studies indicate that it's as high as 1 in 3 women have sexual pain, and these are women typically of childbearing age. In postmenopausal women, that number goes as high as 46%. So that's almost 1 in 2. I mean, 1 in 2, 1 in 3, either way, it's, you know, millions of people we're talking about. And it's not really talked about. The highest numbers I've seen is actually in the postpartum population, women that just have babies. And this study just came out in the end of January of this year, 2015, in case you're watching this in, you know, another year. But,
Right.
And it was in an international journal of obstetrics and gynecologists. And it was done by some Australian researchers in like 6 different Australian hospitals, and had over 1,200 women that had participated in this study. And they were doing questionnaires, you know, during pregnancy, and then also like 6 weeks after, 3 months, 6 months, 12, and 18 months after. And, you know, it was pretty astounding, the results that they had presented in their research, that 9 out of 10 women postpartum experience painful sex on their first attempt back at having intercourse. And the numbers were actually insignificant, whether they waited until that 6-week checkup or they even waited 3 or 6 months between, you know, it didn't matter whether you waited 6 weeks or 6 months, you know, that the numbers are still that high for women that experience painful sex. And of the women that were experiencing painful sex, which was almost 90% of women, it was like 86 point something %. So of those women, a third of those women were still having were still having painful sex at 18 months. And it's just like, we seriously, like there's like 33% of women still a year and a half after their baby is born are still having painful sex. And, it's so hard. I understand. I have 2 kids myself, ages like 5 and 8, they're young. And, there's so much change anyways when you are starting a family with little ones. But then now if you start to lose that intimacy because it hurts, or you're afraid it's going to hurt because historically, since you've started, having sex again, it does hurt. That's really going to impact the relationship with your partner. And
or if you're faking it, like pretending.
Yeah, they think everything's okay, and you're like, no, not really.
It's going to damage the self-esteem. But I think, in those women anyways, the frequency probably goes down, in part just because of being a mother and having more responsibilities and fatigue, and but how much of that is also related to it just hurts. So I'm going to make up some excuse. I'm just going to say I'm tired, but really in reality, it hurts. And, I've seen many women, and this is, one of the first studies that I'm aware of, at least, that talks about these kind of sexual problems postpartum. And it's huge. I mean, 90% of women, like, are you kidding me? Why was this not all over the Today Show for all these stay-at-home moms so they could see it in the morning and know that they weren't alone? Because a lot of them feel like they're the only ones, too, that have this.
It's so interesting, too, because, like, when I was pregnant with my daughter and she just turned 4, I had a lot of women, like friends or kind of friends of friends, who said, afterwards, sex is going to be so painful. And they didn't say it like, I could do anything about it. They said it like it's normal. And a couple women said, like, and it's really going to hurt for at least a year. And that's just kind of like what they put up with, and it's like, even when women are talking about it, they just think it's normal and there's nothing they can do about it. So it's just kind of this interesting, it's kind of, you're stuck in there.
That's one of the biggest problems, I think. And it's sort of fed by the medical community, because doctors, they don't know what to do about it. Like, they might realize it as a muscle thing, but maybe they haven't heard of pelvic floor physical therapy, or maybe, there wasn't like a good pelvic floor physical therapist. They had tried it, it didn't work, but maybe it was just that therapist that didn't work with that patient. So, pelvic floor physical therapy is amazing for these kind of pains. And it's like the main thing you can do. I mean, you can't have surgery. You can't remove anything. There's
Line's not helping.
It's muscle, it's tissue, it's scar tissue. And also really interesting, which I think, we should talk about related to that same study, was, a lot of people are like, oh, it's probably because they had a vaginal delivery. And there's so many women having, elective C-sections, just trying to like spare everything in the vagina, like want to keep it new and fresh. And, what the study showed is that, so half of those 1,200 women, almost half, had natural vaginal deliveries, like uncomplicated, no forceps or vacuum, and about 30% of them had C-sections. So the women that experienced more pain were the C-section group, and then the vacuum assisted vaginal delivery. So the women that they were 2 times more likely to have pain than the natural vaginal delivery.
That's so
anyway, it's just something kind of keep in mind, ladies, if like you're hoping everything's gonna be there's other, there's just other factors. And the study had talked about, using this as a way to sort of research ways to prevent painful intercourse in women.
That's where my mind was going too. What is the prevention?
Right. So I think it's hard to prevent. I think they kind of have the wrong conclusion. Honestly, I think the better conclusion is this can happen. There's so many variables that can happen during childbirth, to how long you push, how big the baby is, whether you needed to have an emergency C-section or it required some sort of assistance to get the baby out, like forceps. So how are you really going to prevent it? Like you can't plan for every eventual scenario. I think the bigger message that should be sent out after that study is, wow, okay, this happens a lot, and what can we tell these women so that they don't feel like this is, the way they have to just kind of resign themselves to this sexual life or lack of a sexual life. There are things that they can do about it. So I think the bigger message would be in management and treating it more so than preventing it. Yes, great, it's always great to prevent injury. I just don't know how practical it is in this case with all the variables at play.
Right. So let's dive into that then. So how do we manage it? I know you have a book all about this.
Yeah, and so, seeing the right pelvic floor physical therapist and having a good program, using the dilators, um, and working on any scar tissue that might be present, addressing lubrication issues. There's not one lubricant that's best for all women. Some women prefer water-based. One of my favorite water-based lubricants that a lot of patients like as well. They love slippery stuff and good clean love. Those are two really good
Those are great names.
ones. There's also silicone-based lubricants, which tend to be longer lasting. So especially in the earlier postpartum periods when you're breastfeeding and your hormone levels have shifted just so that you have a lot more vaginal dryness, longer lasting lubricants tend to do better. And that would be like the silicone variety. Uber Lube is a really, really good one. Patients like it. It also has vitamin E in it. And there's even lubricants that have aloe. They're aloe-based. Desert Harvest is a great aloe-based lubricant. And oil-based, Yes, which is a UK-based company. They have a great oil-based lubricant, or sometimes even just using natural oils like coconut oil or olive oil. Some women prefer to just kind of be, natural, one ingredient. And oil ones tend to be a little longer lasting as well, along with the silicone. But educating women on those lubricant options. But if lubricant alone doesn't do it, more lubricant's not going to do it either, which is what some doctors will say. You just need more lube. It's like, well, how much? You use half a bottle of olive oil, and it's not going to also great.
Slap yourself.
I know, he's swimming in it. I don't know. So having the right internal, you got to address the inside. You can't. I don't believe you can fix the painful sex by only treating from the outside. You have to treat vaginally, and then you can work your way out from there. Other things that might be contributing to the pain or keeping it in the cycle, like postural dysfunctions, can kind of keep you in that pain cycle. Teaching women how to use the dilators. And dilators, when I'm teaching women, usually they'll get a kit. And the kit starts really small. It starts with a dilator that's smaller than like an index finger. And then it goes up a little bit in size from there. And the goal is to get to a pain-free size to their partner that's equivalent to their partner. And some women feel they're just going like one pass. That way they really know that they got it. Or I'll have, lots of women they're not in a regular relationship. And so they kind of want to go up to larger size to prevent for any eventuality.
Manifesting their
any opportunity that might present itself, they'll be ready to go. Yeah, and it's internal. It's similar techniques. Like if you were seeing me for your neck because your neck was in spasm, you couldn't turn your neck, or it was pinching, or you could feel the whole muscle guarding when you would try to move it. It's massaging the muscles inside. It's doing like pressure point releases, trying to get rid of the knots. You can massage the muscles different ways, like side to side, back and forth, but it's all very specific to muscle work. It's not, no woman has ever experienced anything sexual with any of this vaginal muscle work. It's very treatment focused. And
so I'm curious. So if you're working with a woman and you teach her these things, can she go home and have her partner help her with it? So then it's almost intimacy building there as well.
So that's interesting, and that's a way that I've grown, I think, in my own practice with this, is not having the partner use the dilator, because I have found such a great difficulty in the office to try to use the dilator on the woman. That's where I just use my hands. One gloved finger does all the treatment. And it's because I can feel what the muscle's doing. I know which muscle I'm on. I know if I'm pushing too hard because the muscle starts to guard back. So I can really feel if I'm applying the appropriate amount of therapy for each technique that I do. The woman's tool at home to try to mimic that is through using a dilator. And she can adjust. If something doesn't feel quite right, she can quickly adjust. And the problem if when the partner does it, he's not going to know really how far in he is, or if he's pushing too hard, or is this, am I up, down, left, right? They have a lot of issues with that. And I think also for two very important reasons. One, the woman should do it herself so that she's really sort of taking it upon herself to get herself better. And I always say, if you want to involve your partner, I'm happy to show him like some massage techniques he can do on like your low back and your glutes if those were areas of tension that I found during their first visit. I'm always happy to teach them that. So that's one big reason is that for them to be empowered, that they can take care of themselves. They don't have to rely on anybody else to get them better. So the
husband or partner can pour the wine and run the bubble bath.
Like I'm trying to break that association too. But then the other association I think I found when the partner does it is that they're not really breaking that psychological connection, that their partner is causing them pain. So I think it's really better if that is just, the partner is not involved in any way with the dilators. Like that's what she does and that's her thing. And if he wants to make dinner while she does that or clean the toilets, whatever he wants to do to show his support.
That is actually very sexy.
Right?
Yeah.
Right?
Put the kids to bed. He can do a lot of things while
There's other
doing
ways
that.
that he can show his support other than being involved in dilators. And I think the dilators are just bad. And, when I've had patients that have really refused to use the dilators, not 100% of the time, but when they really want their partner to use them, they take the longest to get better of anybody. Like hands down, it might take them 3 times as long to get better.
So I mean, yeah, that almost sounds like some therapy, like mental health therapy might be good for those women.
And typically if women are not willing to do that themselves, there is some other underlying issue, and I do recommend counseling for them. And for a lot of my patients, I try to pick up on cues, whether, not very many of these women have been abused, which is also another important thing to point out, because that's probably the number one thing every woman has been told, is that they probably have some history of abuse, and that is just simply not the case. I mean, I've been doing this for 13 years, and I can remember every single patient that I've had that has actually been abused. So I don't have the best memory, so I think it's not people, probably less than 30 that have actually any history of abuse. So, that's one sort of misconception that should be cleared up. But also, but for sure, those people have counselors. Like that is without a doubt. I alone cannot manage all of that. But what I usually use sex therapists for, or psychologists that specialize in this type of pain, is through like intimacy building, like you had mentioned. So helping more with intimacy, because of course it's going to affect intimacy. It just is. So I will utilize them more for that reason than sort of getting over whatever deep-seated trauma, when most of them really haven't had a deep-seated trauma.
They just have a vagina.
That keeps getting traumatized by all the doctors telling them that wine will cure their problem, or more lube.
I just keep getting this visual.
just add more lube. Just throw it on there. Pretty good.
Lube alone is not the answer.
Cool. So in the tips that we kind of talked about before, it was take some time to address all the aspects of health. Be open with your partner on your experiences with intimacy and intercourse. And then 3, don't accept that painful sex is normal. You deserve better. Anything else you wanted to note about those 3?
Well, we didn't talk much about the communication aspect, and I do think that's really important, because that woman, that post I read this morning, she was just gritting her teeth. I mean, that she was really only making herself worse with not addressing the problem and just continually like pounding against the wall. I mean, she was only creating more muscle guarding over time. So I just hope that women that see this will have the confidence to talk to their partner and explore treatment options, especially if they've never had or heard of pelvic floor physical therapy. We are all over the country and all over the world. I mean, I know physical therapists all over the US, in Canada, Australia, England, Ireland, France. I mean, we're everywhere. And if you can't find us, then I wrote a book, and you can at least get started with, some techniques on your own with that. And it actually is going to be out in Spanish too on September 5th.
Oh, beautiful. Congratulations.
Awesome.
Thank you.
So what do they look for when they're looking for a vaginal floor therapist?
Well, I think one thing to be cautious of is pelvic floor physical therapy has become a little bit of a because it's such a niche, people want to offer it, but they're not really allowing the time or maybe the resources, or don't have the education to treat it effectively. They're just like, oh, this is a thing we can market. It's great. It's like, there aren't enough of these out there. Let's try to get in on this. So when you're calling around, you would want to ask them what type of, how long have they been treating pelvic floors? What's their experience with treating pelvic pain? Because just because you can treat a pelvic floor, a lot of women will come out taking one course and they're treating incontinence. But how you treat incontinence is not how you treat pain. Doing a bunch of Kegels will typically just make most pain conditions worse in the pelvic floor. Whereas that would be the preferred method of treatment for incontinence. So it's a completely different program. So, how long have you been a pelvic floor physical therapist? How long have you treated pain? What are your success rates? Do you have any advanced certifications? There is a certification called a Women's Health Certified Specialist that some PTs are getting. That's a U.S. designation. I personally don't have that because that didn't come out until the year my first child was born. And, anything that came out after 2007, just forget about it. Like, it's just not so, but that could be an indication that at least they've had some higher level of learning. That doesn't always necessarily translate to clinical skills. So, probably getting a recommendation from your doctor, hopefully, if they are, a good doctor that has those connections, would be a good way to start. But how long have they been a pelvic floor PT? How are their success rates with pain? And even ask them questions like, what can I expect on the visit? What can I expect on the evaluation? What can I expect for follow-up treatments? I think it's perfectly fair to say to ask them about how long will it take. And, my response is that it's really hard to tell, because until I evaluate you, it's hard to know how long it will take. I don't even know when I'm talking over the phone if someone can insert a tampon, or if their only problem is sex. They can do every other size except like their extra large husband. They can't do, So, those are some key things to ask. And it's, don't expect an answer in the first few visits, how long it'll take, but you should notice with any kind of sexual pain, you should notice within the first 4 visits, or like the first month, that you are moving in the right direction. If you have no change in your status after a month, you need to move on. I can't think of anybody that I've seen probably in the past 7 years for this that did not start to make improvement within a month.
Beautiful. Okay, so tell us a little bit about, your book and where people can find you.
So my offices, they're actually both in LA. So
okay.
You're a little confused. One is in a city called La Cañada, Flint Ridge, which is near the Rose Bowl, near Pasadena. And that's sort of like a northeast LA. And then my other office is in Tarzana, which is sort of a lot further west of that, going closer to Ventura County. So I'm kind of spread out, geographically available to a broad swath of Los Angeles. My book is available on Amazon, and also that's the only where the print book is available. The ebook is available anywhere you can get an ebook, and the Spanish book will also be available anywhere you can get an ebook as well. So that is that. And, if you live in LA, if you're, lucky enough to be here where it never rains and is always sunny, my office phone number is 818-864-6732. Or you can always just email me directly through our contact form on our website, which is www.fusionwellnesspt.com. So that's a PT at the end for physical therapy.
Fantastic. Thank you so much, Heather. Morgan, anything else before we close?
No, and we'll put links to all your stuff too. When we post it, we'll have it below so everyone can check you out. And thank you so much. This is so awesome. And I love that your book is on audio, because that is like the only way I can read books now.
Well, it's not on audio. Did I say audio? It's the e-reader.
E-reader, perfect. Yeah.
Audio? I don't even know.
Probably they have like things that they can, like, if it's on, you can download it, then it'll play through your phone and
I
off.
read it.
My website does have some materials from the book for download, like a progressive relaxation script I have on my website under resources, and like a sort of a self-check, but it's sort of more designed to go along with the book. So having the book is a little bit easier, but it's like a larger size printable copy, so you can keep track of like your starting levels of pain, what dilator you're starting with, and be able to track your progress as you go. But it's really just designed to empower women to take care of themselves and their problems, because clearly their doctors are not going to.
Oh, such a bummer.
Yeah.
Awesome. Okay, well, we are running out of time, so thank you so much. I really loved having you and chatting with you.
Fun. Thank you.
Cool. Okay, goodbye.
Bye.